Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurophysician from Rajahmundry, Andhra Pradesh, India. My email is 3klpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with the series of lectures of Prime Neurology. There are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Right now we are on part 29 Prime Neurology. Prime Neurology part 29, Parkinson's disease part 1, idiopathic Parkinson's disease. Parkinson's disease is idiopathic Parkinsonism without evidence of widespread neurologic involvement. Parkinsonism is a general term used to define a syndrome of bradykinesia, slowness of voluntary movements with rigidity and or tremor. What are the cardinal motor manifestations of Parkinson's disease? Easy to remember is with an acronym TRAP. T-R-A-P. T is for tremor. Usually they will have a resting tremor and it is asymmetrical to begin with. So one of the important motor features of Parkinson's disease is tremor. That too a resting tremor, and it usually begins asymmetrically. That means it begins one side. This tremor is very prominent with rest and disappears with activity. So the tremor is very prominent at rest but disappears with activity. So one way of differentiating Parkinson's disease tremor with essential tremor is asking him to do an activity. For example, ask him to take a glass of water and ask him to sip it. Resting tremor, Parkinson's tremor, when he takes the glass of water and tries to sip it, the resting tremor disappears with activity and he is able to sip the water without any spillage. Whereas essential tremor keeps on worsening with activity, and when they try to sip water from a glass of water, there's a spillage. So a very good bedside way of differentiating Parkinson's tremor from essential tremor is asking him to sip from a glass of water. Parkinson's disease tremor, since it's a resting tremor, it disappears with activity and therefore they can sip the glass of water well. Whereas essential tremor, it keeps on worsening with activity and therefore there's a spillage of water when they try to drink a glass of water. So very important bedside way of differentiating Parkinson's tremor from essential tremor is asking to drink from a glass of water. So the classic feature of idiopathic Parkinson's disease is tremor. It's a resting tremor and it is asymmetrical to begin with. Second, TR, rigidity. They have rigidity, especially cogwheel rigidity. What is cogwheel rigidity? They have a lead pipe rigidity superimposed with tremor. Lead pipe rigidity means the rigidity will be present throughout equally. It affects both anti-gravity, it affects both flexors and extensors equally, and the rigidity is also equal throughout. That's why it's compared to lead pipe. But when the lead pipe rigidity is superimposed with tremors, we call that as cogwheel rigidity, and it is very classic of Parkinson's disease. So when we check the tremor, it's like this, cogwheel rigidity. It's like a cogwheel. So it comes like this. A lead pipe rigidity superimposed with tremors. So tremor, rigidity. Third is akinesia. There will be slowness of movements. When they walk as if they are walking in a slow motion. They walk very slowly. They have an expressionless face, and there is no arm swing also when they walk. So when they walk very slowly with stoop posture, and if someone calls them also, they'll turn very slowly like this. It's as if they are doing it in slow motion. So there will be akinesia. There will be bradykinesia, slowness of movement. And fourth important characteristic is postural instability. So generally when we try to sit from a standing position, we make a fine adjustments in the movement. Like we pull the chair forward and then we go backwards and then sit. So these fine, delicate postural adjustments are not seen in Parkinson's disease, and they come and sit mechanically as a robo. They don't make such fine postural adjustments. This is known as postural instability. So the classic features of Parkinson's disease is easy to remember with an acronym TRAP. T-R-A-P. Tremor, rigidity, akinesia, postural disturbances. The other motor features are micrographia. They write in very small letters. Masked faces or hypomimia. That means expressionless face. You crack a joke, they'll be just looking like that without any laughter. And there's some tragedy story going on, still they look like that without any kind of emotions. So they have an emotional face. They have reduced eye blinking. So the normal eye blinking rate is reduced, and they have a reduced eye blinking. Since they are not able to swallow well, since it affects all the muscles of swallowing also, they have difficulty in swallowing. Since they have difficulty in swallowing, there is a drooling of saliva. The saliva keeps drooling. They have a soft voice, hypophonia. They have difficulty. Freezing. What is freezing? They are not able to move. They suddenly stand still. Both contraction of agonist and antagonist. So they are not able to move forward. They stand suddenly still. This is known as freezing. So these are the other motor features. What are the other motor features? Micrographia, masked faces, reduced blinking, drooling, soft voice, dysphagia, and freezing. The other non-motor features, in fact, these non-motor features may predate the onset of Parkinson's disease clinically by many years. So one is very careful, vigilant, they can pick up Parkinson's even before the motor features develop. So what are the non-motor features which may develop even before the clinical manifestations of motor manifestations of Parkinson's disease? One, there is anosmia, loss of smell. Second, there is sensory disturbances. They can have pain. They can have mood disturbances, depression, sleep disturbances, rapid eye movement, sleep behavior disorder. Generally, we have two stages of sleep: NREM, non-rapid eye movement; second, rapid eye movement. Dreams occur during the rapid eye movement phase. So nature has given a wonderful protection in the form of hypotonia during REM sleep, so that we don't enact our dreams. But Parkinson's patients may have rapid eye movement sleep behavior disorder. They can have other autonomic disturbances like orthostatic hypotension, gastrointestinal disturbances, genitourinary disturbances, sexual dysfunction, cognitive impairment, and dementia. What is the differential diagnosis of Parkinsonism? So the typical Parkinson's disease, what we call as idiopathic Parkinson's disease, it may be sporadic, it may be genetic, or dementia with Lewy bodies. So this is a typical Parkinson's disease. Then we have the atypical Parkinson's disease, sometimes known as Parkinson's plus diseases. That means they do not only have Parkinson's disease, but they have associated findings also, because it's a widespread disease. So typical Parkinson's disease, then we have the atypical Parkinson's disease, otherwise known as atypical Parkinsonism. What are they? Multiple system atrophy. They can have cerebellar type, they can have Parkinson's type. Usually it is associated with postural hypotension. Second is progressive supranuclear palsy, PSP. They have a vertical eye movement disorders. They have frequent falls. Again, there is a Parkinsonian variant, there is Richardson variant. Then we have corticobasal syndrome, usually seen with an alien hand syndrome. The hand is not under their control. Then we have frontotemporal dementia. So atypical Parkinsonism, multiple system atrophy, cerebellar type, Parkinson's type, progressive supranuclear palsy, Parkinsonism type, Richardson variant, corticobasal syndrome, and frontotemporal dementia. Then we have secondary Parkinsonism, secondary to some other cause. What are they? It could be drug induced, tumor, infection, vascular, normal pressure hydrocephalus, trauma, liver failure, toxins like carbon monoxide, manganese, MPTP, cyanide, hexane, methanol, carbon disulfide. Commonly we see the drug induced Parkinsonism. In psychiatric disorders, the psychiatrists give dopamine depleting drugs so that their mania comes down. Dopamine is a chemical substance which can produce two important manifestations. One, dopamine can cause happiness. Second, dopamine causes kinesia. So when the dopamine is at an optimal level, the happiness as well as the movement is also at an optimal level. But when the dopamine becomes more, like schizophrenia, they become excessively happy, maniac, and they become excessively, there will be excessive kinesia, they will be moving frequently here and there, they become violent. So to reduce these manifestations, they give dopamine depleting drugs. So what happens when they take dopamine depleting drugs? Dopamine comes down. When the dopamine comes down, the happiness comes down. So they are depressed. And when the dopamine comes down, the second important function, the kinesia also comes down. So they become akinetic. So drug-induced Parkinsonism, that means especially dopamine depleting drugs can cause secondary Parkinsonism. The other neurodegenerative disorders that are associated with Parkinsonism are Wilson's disease, Huntington's disease, neurodegeneration with brain iron accumulation, spinocerebellar ataxia type 3, Fragile X associated ataxia tremor Parkinsonism, prion diseases, X-linked dystonia Parkinsonism, Alzheimer's disease with Parkinsonism, and DOPA responsive dystonia. DOPA responsive dystonia is usually seen in young people and they are excessively sensitive to DOPA. So any young person comes with dystonia, always we can give a trial of DOPA, and if they are DOPA responsive dystonia, they have an excellent clinical improvement. What are the risk and protective factors for Parkinson's disease? The risk factors are some genetic predisposition plus exposure to environmental toxins, example pesticides, oxidative damage, free radicals, some degree of neuroinflammation. The protective factors are caffeine use, ibuprofen use, exercise, regular moderate to vigorous, gout, elevated uric acid levels, and smoking. We may be surprised how smoking is a protective factor for Parkinson's disease. The underlying mechanism is that smoking releases dopamine, that's why they get happiness. People who smoke get happiness because there is a dopamine release. When there is a dopamine release, Parkinson's disease is less commonly seen because Parkinson's disease is a disease because of dopamine deficiency. So when they smoke, there is a dopamine release, so it is less commonly seen in smokers as compared to non-smokers. So these are the wonderful concepts of Parkinson's disease. I hope you have enjoyed listening to these wonderful concepts of Parkinson's disease. The other important concepts of clinical neurology, I put it in a book called Exam Oriented Clinical Neurology, written by me, Dr. Sreenivas, published by White Army Publication. This book will be very useful for students appearing for clinical neurology exams. The other book I have written is Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. This book will be very useful for students appearing for oral exams or Viva exams because it contains the theory elements of neurology in a question answer format and will be very useful for students. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said earlier, there are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Just now we are done with another episode of Neurology. If you have liked it, please like, share and subscribe my YouTube channel, Dr. Sreenivas Medical Concept, which is India's leading neurology educational YouTube channel, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.